CT and MR of spine infections for about the next half hour. Our learning objectives are pretty straightforward. We're going to teach you how the pathophysiology and particularly the vascular anatomy help to determine the imaging appearance of spine infections. We'll learn to critically assess which imaging options offer the greatest sensitivity, both for initial diagnosis as well as post-treatment assessment. And this is a real bugaboo for me, probably for you as well, to be able to differentiate spine infection from common mimics, most notably degenerative disease. Now, my colleagues in infectious disease are able to differentiate extremely easily. They just order a biopsy in everybody. So it's really my self-interest that has led me to try to refine this diagnosis and try to really differentiate spine infection from the more common degenerative disease. Now, as you'll see when I discuss the vascular anatomy, primarily what we're speaking about is a disc space infection. And that's an inflammatory process involving the disc and adjacent vertebrae with extension typically to the epidural space and paravertebral soft tissues. And people use a lot of different names, and I would advise you not to use the term discitis. If you think it's infection, say it's infection. If you think it's in the disc, tell them it's in the disc. If you think it's in the vertebral body, tell them it's in the vertebral body. But if you think it's infection, say infection. The major pathway is hematogenous spread to the spine from another infection, like a urinary tract infection or a pneumonia. Staph aureus is the major pathogen, accounting for well over 50% of cases. But Pseudomonas is a major player, particularly in the IV drug abuser population. And risk factors, in addition to IV drug abuse, include age over 50, infection in another part of the body, and diabetes. Let's have a look at the vascular anatomy. So, as I intimated before, the typical spread is arterial to the spine. The distal vessels with slower flow are at the end plate and or the intervertebral disc. And so the typical pattern of involvement that we see on imaging is disc space involvement and involvement of the adjacent end plates. Now, kids and adults are a little bit different, and I'm going to show you this differentiation. In the child, vascular channels cross the growth plate, so the disc is relatively vascular, and the primary infection from this hematogenous spread is within the disc, but then it spreads very quickly to the adjacent vertebral end plates. In the adult, the disc is relatively hypovascular, and so the initial infection is in the vertebral end plate or end plates, with secondary spread usually within a few days to the intervertebral disc. Once the infection becomes established within the disc space, there is venous spread to the epidural space, sometimes giving you an epidural phlegmon, sometimes giving you an abscess, and I'll show you how to differentiate those, and also to the paravertebral soft tissues. Unfortunately, the clinical picture of a disc space infection is pretty nonspecific. It's progressive spine pain, constant, no relief with rest. There's a neurologic deficit in only a small minority. I think that looking at the SED rate or the C-reactive protein is useful because, at least according to my spine surgeons, if your SED rate is not elevated, you really don't have a significant spine infection. The problem is that if you have infection somewhere else in the body, the SED rate is going to be elevated whether you have a spine infection or not. Blood cultures are pretty variable. I think a lot of these blood cultures are taken after one or more of the patient's infections are at least partially treated, and so these symptoms are very nonspecific. Well, is plain film any good? I mean, a lot of us will screen for back pain with a plain film. And in this case, if you really zero in, you'll see that there are poorly defined end plates. And remember that vascular anatomy that I taught you. That's the first place where you're going to look. You can see a nicely defined end plate here. You can see the sclerosis. You can see the sharp margins. You come down here and you've lost that. And you'll be able to see that on plain film. You'll be able to see that on CT. And I'm going to show you how you can see that on MR as well. But even those early findings, at least on plain film, will lag 2 to 3 weeks after the clinical symptoms. As the osteomyelitis progresses, you can see that there's more bone destruction. And later findings include bone sclerosis and progressive loss of stature. This is obviously late in the infectious process. Chronic osteomyelitis will often heal with ankylosis and kyphosis, as I've shown you on this plain film exam. Let's move then to CT. Well, we know that we should have involvement of opposing end plates and an abnormal disc space. And I almost don't have to point out the findings here on this sagittal view. Notice the well-defined end plates here. There are virtually no end plates here. And certainly the intervertebral disc space is involved. You can see the paraspinous involvement even on this non-contrast CT. Obviously, the epidural component is a little bit more challenging, and contrast can really help you if you're going to do a CT evaluation. Chronically, here is that ankylosis and kyphosis that I showed you on plain film. But one of the things that I really like are the 3D reconstructions, because you can see the calcification and ossification that has occurred in the soft tissues as a result of that venous spread, resulting in the ankylosis that we see. Okay, the real workhorse, of course, is MR. So I'm really going to focus on MR findings in spine infection. Let's just start with a T1. Where are we going to look? We're going to look at the disc. We're going to look at the vertebral end plates. And you can see here that we've got some low density and at least a questionably abnormal disc. Let me blow that up for you so you can see a little bit better. Well-defined end plate, well-defined end plate. You come down here. Where's my black line? Where's my end plate? Where's my end plate? Okay, so at least on a T1, one of the areas where I go is to look at those end plates. Now, in this case, you can probably see that we've got an epidural component and we've got a paraspinous component as well. We can see those components a little bit better on the T2. We're also seeing that there's T2 prolongation or T2 bright signal involving these vertebral bodies and kind of plus minus within the disc. Discs are a little bit difficult because sometimes these discs are degenerated, and when they're degenerated, you just don't have very many water protons to give you much of a signal. You can certainly see the paraspinous component and a little bit of epidural component, perhaps a little bit better seen here off axis. Now, as I told you, my major problem is differentiating spine infection from Modic Type I changes. So I decided to review the Modic Type I changes, and for historical interest, I went back to Mike Modic's original article from the 1988 Radiology, and if you look at the quality of these images, thank God we've come a long way. But what Dr. Modic pointed out is in these Modic Type I degenerative changes, the end plates are T1 dark, and you can see that here, but then they brighten up on T2. The disc space is dark on T1, dark on T2. So I've put together a little chart here, and we're going to expand this chart as we add various imaging sequences. And you can see that it's pretty difficult to differentiate infection from Modic Type I changes just using a standard T1 and T2. Really about the only place that you can focus is to look for increased T2 signal intensity of the disc. And even that is not always present, but that's where you want to focus when you're looking at least at a non-contrast MR. Okay, so let's add contrast. We'll go back to that cervical spine case that we could see, and you can see that the disc and vertebral bodies show contrast enhancement, and the contrast enhancement really can help you with the epidural and paraspinous components of the infection. Let's look at a lumbar case. We'll start out with a T1, a T2, and a stir. One of the reasons I show this case is if you're really trying to go quickly, I would rather look at a stir than at this T2. Everybody buy in on that? I think you can see the T2 prolongation a little bit better because of the inherent fat saturation in the stir imaging. So if you're trying to go quickly or your ED is asking for a lot of total spines, what you might want to do is do T1 and stir and maybe a few other sequences like a contrast enhanced. Let's look at the contrast enhanced. Here is our T1. You can see the low signal, and then that kind of fills in on the post-contrast. Notice, though, that the disc space looks dark here, and boy, to my eye, it still looks dark here. So let's enter this data into our chart and see if contrast enhanced helps us. Well, it helps us some of the time. If you see the disc enhance, it pushes you toward infection, but the problem is that it's not always present. So that is not as much help as we would hope. This is a pretty easy diagnosis. I think everybody would be able to diagnose the epidural component, the abnormal disc space, the abnormal vertebral bodies, and the paraspinous component. We can add a T1 with fat saturation, and this really helps me to appreciate the circumferential nature of the epidural phlegmon in this case. And remember I told you that I was going to teach you how to differentiate phlegmon from abscess. Phlegmon will show you solid enhancement. Abscess will show you only peripheral enhancement. Let's look at an example. This is obviously a different case. We're looking up here in the cervical spine, and you can see that there is some abnormal brightness post-contrast within the C2 vertebral body. You see a small anterior epidural collection with low density. This is the abscess, and this is surrounding enhancement. So this is an example of an epidural abscess. Now, in this case, we also went ahead and got diffusion-weighted imaging. One of the things that we noticed is that our trainees at the University of Arizona were having a lot of trouble with these spine infections, and they basically are our first line at night. And when it's 3 in the morning, I want that first line to be intact, making good diagnoses and being pretty confident about their diagnosis. So we started to do diffusion-weighted imaging, and these diffusion-weighted images are not the prettiest things on the block, but notice how nicely you can see the restricted diffusion, and if you really squint, you can even make it out on the ADC that shows you the epidural abscess in this patient. Now, according to the literature, and I say according to the literature because in my hands this was a little bit difficult, diffusion-weighted imaging can reliably, know about that, differentiate Modic Type I end plate changes with no restricted diffusion from the abnormal end plates in a disc space infection. Well, this sounds pretty good, but unfortunately people were turning up some restricted diffusion even in the Modic Type I changes. And so I've added this to the chart but I've sort of given you a little sideways arrow here that, yeah, you should have restricted diffusion within the end plates. Sometimes that occurs within the disc, but not always. So can we refine this a little bit more? And a few years after, one of my former fellows actually published this paper. And he stated that a third of the patients with Modic Type I changes and T2 prolongation within the disc are really degenerative disease rather than infection. And that's the conundrum we'd been dealing with. So he applied diffusion imaging and described the claw sign. And it's important to really wrap your head around this claw sign because it may not be that intuitive. It's defined as well-marginated, linear regions of high signal within the adjacent vertebral bodies, not necessarily right at the end plate. And a positive claw sign is degenerative disease, not infection. Let's look at some pictures. This is from Dr. Patel's article. You can see maybe it's modic, maybe it's infection type changes. And here is the claw sign. Notice that the end plates aren't so much involved, but this band or linear area of restricted diffusion within the adjacent vertebral body marrow. This is a positive claw sign. This implies degenerative disease. Okay? And then he went through and he had different classification systems. This is about what we would expect in a disc space infection. Abnormal disc, abnormal vertebral bodies, abnormal end plates. This is the claw sign. No restricted diffusion within the disc, and then these linear areas of marrow involvement that define the claw. And unfortunately, a lot of cases fall in an indeterminate range. And what they did is they put together an algorithm, and this is really the algorithm that I use. So patient symptomatic, symptoms are nonspecific, so we're not quite sure what to do with those, but it could be a modic pattern. What do? We look at the disc. Is the disc bright? If it's not bright, infection is unlikely. If the disc is bright, we haven't solved our problem yet. We can throw diffusion-weighted imaging into the mix. We can look for the claw sign. Positive claw, remember, is infection unlikely, most likely degenerative disease. If there's an absent claw, then you're kind of stuck saying, yep, this could be discitis, and the patient usually goes to biopsy. Okay, here is a bit of a problem case. Have a look at the C6-7 level. The disc is T2 bright, it enhances, but the end plates are dark and not enhancing. What are we going to do? Well, of course, we are going to try to do diffusion. This is one of my cases of a claw sign. We were able to avoid biopsy in this case. This is degenerative disease. Another sign that might help you out is the Psoas sign. And the problem, of course, is that lumbar discitis osteomyelitis has characteristics that overlap with non-infectious causes. So look for psoas hyperintensity. Pretty easy to pick this out. Psoas hyperintensity, psoas hyperintensity, no hyperintensity, no hyperintensity. This is infection. This is degenerative disease. But a useful sign, even on a non-contrast study. Let's now look at the time course of spine infection. And I like to follow this on a contrast-enhanced T1. Here we've got multiple components: abnormal disc, abnormal vertebral bodies, abnormal epidural, abnormal paraspinous. We did a biopsy. Following the biopsy, antibiotic therapy for 2 weeks, and look what's happened. There's now no abnormal epidural enhancement. Paraspinous has decreased, but there is persistence of enhancement here within the vertebral bodies and within the intervertebral space. So, if you're getting a follow-up, where is your eye going to go to be efficient? What you should be doing is starting your interrogation by looking at the epidural space and looking at the paraspinous soft tissues. That's going to save you some time. That's going to increase your accuracy. Let's look at another case. Here we've got a multifocal epidural abscess. 10 weeks this time of antibiotic therapy. Obviously, that was a pretty nasty infection. And look what's happened. The epidural component is much reduced, perhaps cleared away. So your eye should go to that epidural space, even when you have abscess. If you have prolonged antibiotic therapy, you can clear that infection. So if possible, follow with a contrast-enhanced T1, use fat saturation. Earliest changes, epidural and paraspinous. Last to show change are the vertebral bodies. And if you think about it, these changes reflect the vascularity of the tissues involved. So it all makes sense. Now, I talked about hematogenous spread, but clearly you can have spread from an adjacent organ. Abnormal chest x-ray, you can see on the CT, you've got a lung abscess, and it's extending here to the spine. Classic findings of a disc space infection. Contrast helps. You can see the epidural findings, and, more of the same. Facet injections. A lot of times we don't pay as much attention as we should to the facets. In this case, it was hard to ignore. And then we looked at the axials, and you can see that there's a lot of infection going on here centered on this facet joint. And of note, there's a lot of epidural disease as well. So in somebody where you're looking for spine infection, I'm looking at the disc spaces first. I'm looking at the vertebral end plates. But before I put this case away, I look at the facet joints as well. Let's look at a case of TB. Now, TB is a real fooler. Remember I told you that in hematogenous spread to the spine, we go to the disc, we go to the end plate, and then we spread because there are proteolytic enzymes, and the proteolytic enzymes quickly colonize the disc in the adult and the end plate in the child. Well, what if you're dealing with an infection that doesn't have proteolytic enzymes like TB? It's going to stay in the bone. It's not going to go to the disc, and it's not going to cross the disc space to involve adjacent vertebral body. So you get a picture like this. And I'll tell you, the first thing I think about when I see something like this is probably not TB. I'm thinking about a malignancy. And I'm thinking about a malignancy, right? You've got marrow replacement. End plates look pretty good. Intervertebral disc's not bad. Hey, we all know that malignancy can spread to the paraspinous regions, and a lot of these cases go to biopsy. So many of these cases go to biopsy that I do the spine biopsies at my place. And so when something that looks like this comes in and it says, evaluate for neoplasm, I put on a TB mask, and I ask my team to put on a TB mask as well, because occasionally something that's advertised as a neoplasm comes back as TB. Okay, you can look at the T2, I don't know, still looks like neoplasm to me. Look at how nicely defined those end plates are. And even contrast doesn't help you all that much. Okay. I'm from Arizona, so I got to show you a case of cocci. And cocci is a great mimic. If you're not living in Arizona or California, you're probably not going to see very much of it, which is actually going to make your life easier. Abnormality here within the vertebral body, God only knows what that is. It turned out to be cocci. Here it looks like we've got something in the spinal cord. God only knows what that is. It turned out to be cocci. This one's a little easier. You can see there's massive lung involvement. It has extended to involve the spine. It's involving rib here. I think most of us would put Cocci pretty high in our differential, but it can look like just about anything. It can be pretty messy. Speaking of a messy case, I'm going to show you one of the really nasty ones that I've seen here. A lot of times we'll get a CT within the first few days following surgery just to make sure that the hardware is in good position and, graft material hasn't migrated and all that. I mean, one question I would ask is, okay, man, you operated on this level and everything looks good. Was there some reason you didn't want to operate here? Maybe they'd done a flexion extension and this guy was fused here, so there wasn't too much they could do. In any case, we gave him a clean bill of health. Great job. But after 17 months, the patient returns, obviously not doing well. Disc space involvement, end plate involvement. What are we dealing with here? Well, we're certainly very concerned about infection. Sorry. So what they tried to do was a laminectomy and a kyphoplasty, and that didn't really turn out too super well. You can see the cement here. I guess they were able to get some stabilization, but it didn't really help the infection all that much. You can see here that there is some stenosis, worsening spinal stenosis. The infection is just going crazy. And they ended up with a major reconstruction here, and notice that they had to dig out all that cement. So sometimes these turn out to be pretty gnarly cases. Well, what have we learned? We reviewed the plain film, CT, and MR appearance of the common spinal infections, and we realized that those don't always allow us to differentiate from Modic type changes, particularly Modic type I degenerative changes. So we added the claw sign, which it means you need to do diffusion, and we added the Psoas sign, which means that I usually do it on the axials. You need to look carefully at the T2s. We talked about how the vascular anatomy determines the initial site of infection, a little different in kids and adults, and then the spread of infection. I illustrated the time course of spinal infection, particularly where do you look to see the very earliest changes. Then you're going to look in the epidural space and you're going to look at the paraspinous soft tissues. And then we analyzed the components of the spinal infection, talked about where those early changes might be seen. Thank you so much for your kind attention.